The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. This is Quinn Mulholland with the National Housing Conference. We really appreciate everyone taking the time to join us today for this very important webinar. I'm sure everyone is incredibly busy, so we're going to try to make this as productive and informative as possible. We'll be discussing COVID-19 and housing with two experts in public health and epidemiology today. Before we do introductions, I'm just going to go through a little logistics about the webinar today. So the video, as we said in the email, will be posted online afterward. So for those who weren't able to make it today on the webinar, you will be able to watch the recording on our website, and we'll send around the link to that once that's published. Right now, everyone is in listen-only mode. So if you have any questions, which I'm sure you will, and we definitely want to get around to as many people's questions as possible, you should see in the right-hand control panel an option for questions under the control panel. So folks should go ahead and use that as a way to ask questions. And once we finish with the presentation, we will get into the Q&A section, and we will ask your questions to the experts in public health and epidemiology. If you have any other comments or issues during the webinar, feel free to use the chat function also under the control panel. Alternatively, you can always email me. My email should be on everyone's screen right now for you to see. It's qmulholland@nhc.org. So again, please feel free to email me with any questions or comments during the webinar. And with that, I'm going to hand it over to our President and CEO, David Dworkin.
Thank you, Quinn. Good morning, everyone, and thank you for joining us. This is a critical time for our country, our families, and for housing leaders in particular. As we've discussed through our member notes, please check our website for regularly updated resources and other information at www.nhc.org. Today, we are pleased to be able to provide you with an opportunity to hear directly from public health experts who will provide a presentation and then answer your questions to the extent that we have the information to do so. One of the most important aspects of our response to this crisis needs to be to know what we know and what we don't, and be clear about the difference. Here at NHC, we are committed to helping you provide medically vetted information to inform your organization's decision-making. That said, I'm pleased and grateful for the opportunity to introduce Dr. Mark Dworkin, who, as may be apparent by his name, is also my brother. He and his colleague, Dr. Sinan Almukhtar, have generously agreed to join us and present the latest facts on this rapidly evolving pandemic. Dr. Dworkin is a board-certified infectious diseases physician with a master's degree in public health and tropical medicine, who was trained in the CDC's Epidemic Intelligence Service program. Dr. Dworkin has worked at the CDC in Atlanta in the Division of HIV/AIDS and served as the Illinois Department of Public Health's state epidemiologist, where he led, presented, and published outbreak investigations and HIV surveillance analyses. He is a professor and associate director of epidemiology in the Division of Epidemiology and Biostatistics at the University of Illinois at Chicago School of Public Health. He is the editor and author of the textbook Cases in Field Epidemiology, a global perspective that teaches outbreak and other field investigations and demonstrates the value of surveillance through illustrative examples of important outbreaks. Dr. Sinan Almukhtar specializes in internal medicine, and he holds a master's in public health. He is currently a PhD student at the University of Illinois at Chicago School of Public Health. So without further ado, I would turn it over to Dr. Dworkin and Dr. Almukhtar.
All right. I will go ahead and change the presenter and hand it over to Dr. Dworkin.
All right, I just want to confirm that you can see the first slide, the title slide.
Yep.
Okay, great. We'll go ahead and get started. As you know, this is an update on COVID-19 for the National Housing Conference. We are medical epidemiologists, and there's a lot of experience in public health. We're not experts in the housing field, but we have given a lot of thought to this in order to try to be helpful to you all, and we hope that this is useful as an update. I am trying to change my slides. Okay, there we go. Here you can see an outline of what we're going to try to cover today. We're going to go through the background on COVID-19, try to understand it and its name. We're going to talk about its spread and talk about how it transmits. We're going to go over the symptoms as well as what we've learned from China so far, and an update on the global situation, an update on the US situation. We're going to talk a little bit about personal protective measures, cleaning and disinfection, some selected guidance for homeless shelters, and finally we're going to address the issue of fear, which is front and center. The last slide is a list, kind of like references to where we got some of the information that we are presenting. You can see here, this is myself and Dr. Almukhtar. And we're going to go ahead and get started. Dr. Almukhtar will lead this presentation.
Okay, hi everyone. We're gonna start talking a little bit like background of the virus. The name coronavirus is derived from the Latin word corona, which means a crown or halo. The name refers to the characteristic appearance of the virus seen on the electron microscope. So the name COVID-19, where it came, the CO stands for corona, as a crown, as we said. The VI for virus, D for the disease, and 19 for 2019. Why we call this virus a novel? So it refers to a virus that never been seen before. Therefore, we expect anyone can become infected with this virus. Now we can see a picture of the virus, of the COVID-19. It's going to show you how it looks like. You can see it's a crown-like circular figure with the crown-like projections. And we want to tell like a difference between this virus and other viruses. So we're going to show you another picture of the Ebola virus, which you might hear of. We just want to show that not all viruses look the same. That's why the name came, like the COVID for the crown shape. If we go to the next slides with the background, so the coronaviruses, it's a big family of viruses. We discovered the first one in 1965. It has lots of viruses. Some of them, like we know about, we heard about, and one of them is COVID-19, the one we're talking about today. Coronaviruses in general can infect humans and animals for a long time. The illnesses that they cause can go from mild, a simple cold, to something more serious, like the one we're facing today. As probably most of you know, it started in Wuhan City, Hubei province in China, in a live animal market. And based on the studies we have so far, we expect there is a bat origin involved in the disease. Coronaviruses in general can infect animals like bats, camels, cattle, beside humans, of course. So we're going to talk about two of these coronaviruses that most of you familiar with. One of them is SARS-CoV. I'm sure lots of you heard about SARS from 2003. So the virus that caused SARS-CoV, is a strain of viruses from the corona family that causes severe acute respiratory syndrome, or what we know as SARS. It started in 2003. We had 8,422 cases began in China and spread at that time, was spreading to 28 countries. Before I talk about like the case fatality rates, a little background about what that term is. So the case fatality rate, we simply measure the number of cases and the number of people died from that disease. So the number of people died, the cases died from that disease over the number of cases of that disease within a certain time, within a defined time, we get a ratio and multiply it by 100, end up with a percentage. That's what we call case fatality rates. So you're gonna hear me talking about case fatality rates a lot in this presentation. So back to SARS. For SARS, the case fatality rate ranged from 0 to 50, with 1% case fatality rate in patients under 24 years old and over 55% among people who are aged 65 and older. But like a similar pattern we can see with COVID-19 now. How did we control that virus? We didn't have a cure. We isolate people, did quarantine, and only supportive treatments. Now I'm going to talk about another member of this family, MERS-CoV. It's a strain of virus that causes Middle East respiratory syndrome, or MERS. It's also a species from the coronavirus family that infected humans, bats, and camels. This virus appeared in 2012. 2,000 cases began in Saudi Arabia and spread to 21 countries. The case fatality rate was a little less than 30%. Which, based on what we know, direct contact with camels is a risk factor for human infection with MERS. And what we did at that time, isolation, quarantine, and supportive treatment as well. So now let's start talking about our virus, COVID-19. How does it spread? First, person-to-person spread. We know that close contact with one another within 6 feet might be a risk factor for spreading the disease. The way of spreading through respiratory droplets produced when an infected person coughs. In different ways, like for example, if the droplets land in the mouth or nose of people when they're nearby, less than the 6 feet, or when these droplets land on surfaces, we touch these surfaces and then we touch like our face, our nose, or our eyes, or through airborne, which still we're not sure about. There are so many recent studies talking about this right now.
Yeah, it's especially an issue in a hospital setting where they're doing certain procedures, but it might have a role in the transmission of this disease. It's still being determined.
So, can someone spread the virus without being sick? This is a new important issue we're dealing with right now. We know when people are the sickest, when they have most symptomatic, they're most contagious. They spread the disease more. But so far, we have 2 documented cases, one in China, one in Germany. These patients were asymptomatic at the time. These 2 people were asymptomatic when they start spreading the disease. Those infected from these asymptomatic cases had mild illnesses and were hospitalized only for public health purposes. So this is a good news that in this case, it's usually mild disease. More research is needed when it comes to this point. Concerns some people have about transmission. So we're going to talk about a few things that people ask us all the time. First question, can packages mailed from China give me the COVID-19 virus? So basically, it is a theoretical risk. There is no evidence to support this, but we can imagine if this is true, we will be seeing much more cases given the volume of importing goods from China.
So it's probably not an issue at all.
It's not, it's just a theoretical risk. Second question that we always hear.
Before you move on, there's data that suggests that it doesn't survive on cardboard for very long.
Yes, thank you, Dr. Dworkin, for the note. So yeah, like experimental data suggests that it doesn't survive 24 hours on cardboard. So when it comes to bigger buildings, we saw many studies in China saying that if we can keep the packages in the mailroom for over 24 hours, that can be a protective measure. Will warm weather stop this outbreak? We keep hearing this over and over. It's unknown. Some other viruses like the common cold and flu spread more during cold time. It makes sense in theory because lots of viruses get deactivated by ultraviolet light, and some viruses don't do well under warm temperature. It is a legitimate thought, but we don't know for sure. Another concern, can my house pet get the COVID-19 virus and give it to me? Okay, so this is also a legitimate thought because some other coronaviruses infect animals, including dogs and cats, but based on what we know so far, it's only theoretical risk and no evidence supporting it. There was a rumor about a dog in Hong Kong that got the virus and died. The studies showed afterward that the dog didn't have the virus and the dog was 17 years old. So again, there is no evidence supporting like house pets getting the COVID-19 and spreading it to humans. What is the recommendations about linens, clothing, and other items that go in the laundry? So few recommendations from the CDC saying that don't shake the dirty laundry. That would help. If possible, use the warmest appropriate water setting for these items and dry items completely. Clean and disinfect like the baskets or like the carts for transporting the laundry.
And this is mainly an issue if you're dealing with somebody who you know or suspect might have coronavirus and you're dealing with their linens or laundry.
Moving to the next slide. This is also like a question we hear over and over. Who should wear a mask? So let's start with the people need to wear the mask first. If you have respiratory symptoms, you need to wear a mask. If you're providing care to individuals with respiratory symptoms, you need to wear a mask. If you're a health worker and attending to individuals with respiratory symptoms, you also need to wear the mask. It's not needed for general public who don't have respiratory symptoms. The CDC saying general public with no symptoms, they don't need to wear a mask.
There's no harm done with wearing a mask if you're frightened and you're just trying to protect yourself and bring your anxiety down, except it's the hoarding of masks. It's the, buying up all these masks that can be found in any sort of store. That's highly disruptive.
We're going to talk now about the symptoms. What do we expect to see? So symptoms may appear 2 to 14 days after exposure to the COVID-19. We would expect to see fever, cough, shortness of breath.
Eventually.
In
those who get sickest.
Yes, it might be mild, it might be asymptomatic, but if we see symptoms, we're expecting these three together or at least one of them. Some patients may also have pain, may suffer from nasal congestion, runny nose, sore throat, nausea, or diarrhea.
Those are usually symptoms you're going to see on top of fever and cough, not instead of fever and cough.
Now we're going to talk about things that we learned from China. Again, we don't know, it's a novel virus, so we're trying to look at what happened in China, what happened in Italy, and what we know about other coronaviruses. So we're going to start looking now in this slide about the biggest study done in China that had almost 72,000 cases, and it was published last month in February 24, 2020. This study had almost 44,000 confirmed cases. And when I say confirmed cases, it means these people were tested with throat swab samples and they tested positive. So 44,000 confirmed cases, almost 16,000 suspected cases, and the diagnosis was based on their symptoms of exposure. No test was done. Around 10,500 diagnosed cases. It's based on the symptoms and history and some imaging, and almost 900 asymptomatic cases.
By imaging, we're talking about X-rays.
Yeah. So this slide, we're going to talk about the age distribution. Unfortunately, the study didn't categorize the age between 30 and 80, but that's the kind of data we have so far. So 3% of these confirmed cases, now we're going to be talking only about the confirmed cases, 3% of them over the age of 80, 87% of them 30 to 79 years old, 8% 20 to 29 years, 10 to 19 years, only 1%, under 10 years, only 1%.
Now, it's important to understand that this was based on whatever processes they had in place early on when this was mainly affecting older people. That is to say, younger people, 10 to 19, less than 10 years, may have been getting it in much larger percentages, but weren't being tested, and therefore they didn't become confirmed cases. So the true distribution of this disease is not displayed here, but this is what we have so far from a large study.
Now we're going to speak about the spectrum of disease. Like if you remember, we said it might be mild, might be serious. We're going to talk about the spread of the disease in these confirmed cases. The good news, 81%, almost 36,000 out of the 44,000 were mild cases. They had pneumonia-like disease, mild pneumonia or no pneumonia at all. 14% of them, they had severe disease. They had shortness of breath, low blood oxygen, and these people might need some supportive measures, or some of them might need to be admitted to the intensive care units. And only 5% of the 44,000 had respiratory failure, septic shock, multiple organ dysfunction, what we refer to critical cases, which most likely would need admission to the intensive care unit.
So on the one hand, it's good news that such a small percentage end up needing critical care. The problem is that it's a small percentage of a giant population, so it ends up being a large number of people who need critical care, and there's only so many critical care beds available. And that's where you can end up with higher mortality, because if you can't give everybody a ventilator when they need it, then people are going to die that otherwise would have been okay.
If you remember when we talked about the case fatality rate, so we're going to talk about the same population a little bit earlier from February 11th. So we're going to start from down and go up. From 0 to 9 years old, there were 0 deaths. Like the case fatality rate was 0. For 10 to 19 years old, 20 to 29 years old, 30 to 39 years old, it was 0.2%. We're talking about 2 people died per 1,000 cases. For people 40 to 49 years old, it's 0.4%. People 50 to 59 years old, 1.3%. 60 to 69, 3.6%. 70 to 79 years old, 8%. And about more than 80 years old was almost 15%, which telling us that the people at risk, people over the age of 70 and 80. And also, like if we looked at the data from the Diamond Princess cruise ship outbreak, 700 people got infected, elderly passengers and crew, the case fatality rate was only 1%.
So we see a much different mortality rate from that unusual sort of natural experiment of the cruise ship. It doesn't represent the US population, it doesn't represent the China population, but it is all represents a relatively healthy in some ways, in terms of like nutrition, elderly people, and we see how the percent is lower here in that particular situation.
Now we're going to be talking about the case fatality rate among critically ill cases, and please keep in mind we're talking about critically ill cases in the same study, in China study. These people had 50% case fatality rate. So we want to see what they had. Higher among the case fatality rate was higher among those with pre-existing comorbid conditions, people who already have diseases. We found 10% for people with cardiovascular diseases, 7.3% higher with people with diabetes, 6.3% for chronic respiratory diseases, 6% for cases with hypertension, and 5.6% for people with cancers. Now we're going to start looking at global data. Now we're done with the China study, we're going to be talking about global data. So distribution of the cases outside of China, March 18th. This data pulled yesterday. We can see the highest countries that they have cases now: Italy, Iran, Spain, Germany, South Korea, France, US. Like if we see here, US coming in the 7th, like ranked 7th. Unfortunately, data from today showing that US went to the 5th place with almost 9,000 cases. Back to global data. So far, based on yesterday's data, we have almost 200,000 cases, 156 countries, and almost 8,000 deaths. The case fatality rate we talked about, almost 4%. The good news is 80,000, almost 82,000 people got recovered. Now we're looking at the total global confirmed cases of COVID-19. As we can see in this graph, there's an exponential rise in the number of cases over time. And we don't want people to get panicked, but that's what we're going to expect to see if there is no measures, without aggressive countermeasures. That's what we're going to expect to see over time. Now we're going to look at this graph showing us the deaths from COVID-19 globally, and same exponential rise in deaths. Now we're going to be focusing on US data. So this slide's from yesterday again. In US, we had 4,226 cases, 49 states, except West Virginia was spared. We had 75 deaths. The case fatality rate was 1.7%. If we look at today's data, unfortunately, this morning we had almost 9,415 cases, 50 states with a confirmed case in West Virginia yesterday, 150 deaths.
So the case count basically doubled. And it's important to keep that in mind, that within one day to the next, that the case count doubled. It again speaks to why everyone is taking this so seriously, because it could double again tomorrow.
Yeah, so we're trying to tell you what we're expecting here. The case is going to keep increasing. The good news that if we do good control and prevention measures, we control the number of deaths, and eventually we can handle this disease. So this is an old map from yesterday. Now West Virginia also had a case, unfortunately.
All right, and you can also see which states are darker. These are the states that have so far borne the greatest brunt of volume of cases. But from day to day, this could change, and other states could, rival them. We will see.
Yeah, unfortunately, right now we have Washington, California, and New York. I don't think we have time for this slide, so we can ask this one. Let's start about basic protective measures against the COVID-19. So what we need to do, basic things.
And you know all these things, but we don't want to leave them out.
So wash your hands frequently, regularly, and thoroughly. Use alcohol-based hand rub or wash them with soap and water. Maintain social distancing. This is important. WHO, World Health Organization, saying 3 feet. The CDC recommended 6 feet. I would go with 6 feet. Avoid touching your eyes, nose, and mouth. Based on 2015 observational study among medical students, people touch their faces, like using their own hands, touching their faces on average 23 times per hour. Maintain respiratory hygiene, like the simple things: cover your mouth and nose when you cough or sneeze, use a tissue, throw it out after you use it. So, wash your hands. We know that everyone listening knows how to wash their hands, but I want you to understand why we're talking about this over and over. First, we need to do it in a proper way. Wet your hands to create an environment for the soap to work. Get the soap, scrub your hands in a good way. Most people do it for a moment. Do it for 15 to 20 seconds. Some people count to 20, some people sing happy birthday, some people do whatever it takes to scrub your hands for 15 to 20 seconds. Rinse your hands in a good way, then dry it.
And this is especially important because we don't know who's having asymptomatic disease but actually has the virus in their mouths and may be contaminating their hands and their own environment. So that's why this is so important, is we can't figure out without extensive testing of the whole population who's moving the virus from person to person. We can certainly recognize who's sick. So hand hygiene has never become more important. And we'll get other benefits from this too, because we're at the tail end of the flu season. We're going to reduce flu. We're going to reduce transmission of all kinds of other things at the same time. There'll be many benefits.
And before we leave the slides, keep in mind, dry hands less likely to spread contamination than wet hands. So please dry your hands. Now we're going to talk about persistence of coronavirus on surfaces, which is an important thing to talk about here. So keep in mind, we don't have full data about COVID-19, but based on what we know so far, what we know about other coronaviruses and viruses similar to COVID-19. The virus can remain infectious for 2 hours up to 9 days, depending on the surface material. At 4 degrees, persistence of TGEV and MHV can increase to almost a month. So these two viruses they have very similar characteristics to COVID-19.
So at cold temperatures, the virus can be preserved a very long time.
Yes. And of course, when the temperature increases, on the contrary, the virus might persist less, the persistence reduced, as we know from MERS virus, which is another virus from the corona family.
But there's no magic answer of exactly how many days or hours, because conditions will vary for every situation. So if you hear a precise number, we still can't count on that. It's likely based on some sort of experiment that was done in some sort of chamber.
Yeah, one of the things that we can know from previous studies, that, as we said, in cold temperature, the virus stays longer, but the virus would stay less if we have less humidity. So if we can deal with the temperature, at least lowering the humidity would help reduce the survival of that virus. And another point that makes a lot of sense, I'm sure, that the more the dose of that virus on the surface, the longer it can persist and stay. On this slide, we're going to be talking about persistence of coronaviruses on different types of surfaces. And why this is important, because it's things we deal with on our daily lives. When we're going to look at steel, for example, we're talking about some doorknobs, kitchen appliances, elevators. When we're talking about aluminum, we're talking about like foils, utensils, window frames, glass everywhere around us, same as plastic, PVC like with pipes, surgical gloves, and ceramic like in tiles, toilets, bathtubs. So these kind of services, we have some data. This is lab setting, but it's just to give you an idea in this study. So if we can look at steel, for example, under the 21 temperature, it can survive for 5 days. For glass, 5 days. For aluminum, it's only 2 to 8 hours. So we know that now, like if you want to compare like two materials, you know what's made of, and we can look at it from that perspective. And again, like if we look at surgical gloves, it's less than 8 hours. Now let's talk about how we can inactivate the virus, like inactivation of coronavirus by using like different chemical agents, disinfection. So I'm sure like if you guys looking at the agents in this slide, you probably gonna recognize the first one, which is ethanol. It's rubbing alcohol, basically it's rubbing alcohol. And the third one, which is sodium hydrochloride, it's what we commonly call liquid bleach. Based on recent study done regarding COVID-19, 1 minute exposure time between these chemicals and the surfaces can disinfect the surface. In the last column, we can see how much it's decreased, and this is on the log level. So based on what we see here, we recommend rubbing alcohol, the first one, and the bleach, the third one. They're highly effective in the contact time between the cleaning material and the surface is 1 minute. I know 1 minute is a long time. We're not asking you to keep rubbing the surface for 1 minute, but keep it wet with that material. So if I'm using the alcohol, for example, to disinfect my surface, don't wipe it. Just keep the contact time for at least 1 minute to lower the survival of the virus. In this slide, we see like some examples of things we look at every day, like door handles, like when you throw your garbage, when you go to the gym, these things that we deal with every day. And when it comes to big buildings, based on recent CDC recommendations, if you can guarantee like really good disinfection, we recommend that you close the gym room in residential buildings, unless you can keep it clean like on an hourly basis. In this slide, we're looking at elevator buttons. Why we have this picture here. So you're living in a building, let's say like you have like 100 people living in this building, all 100 of them gonna touch these buttons every single day. So it's risk factor here. It needs to be cleaned. It needs to be handled in a very good way. And as we can see, like one of the pictures showing that the buttons made of metal, some of them made of plastic, some of them made of glass, is just to show you to like go back to the slide that we talked about and look at the different material and how we need to deal with different surfaces. If you remember, we talked about China, and we want to learn about what these people did. Some simple things, simple ideas they had in China. I got these pictures from my friends in China, scholars in China. Some buildings, they would have toothpicks, and they use the toothpick to press the elevator button, and then there is like this small can, like you can do the toothpick after you use it. They have like the adjusted lighters. They have like a small wire or metal in the lighter. They can use it to press. Then they disinfect it with just using the lighter itself, just to clean it up. Other ideas from China, again, like my friend sent me those. And instead of pressing the elevator, they came with a simple system in their elevators. They can use their feet to press the number for the floor they want to go to. If we go to the next slide. Yeah, so in here, again, like the one in the middle, the same idea, like using toothpick. The first picture, you will see that it's very simple box of tissues. People can pull one, use it to press the button of the elevator.
The picture on the right?
The picture on the right. The picture on the left, it's a different approach. This building, what they do, they have a plastic wrap covering the elevator buttons. and every 30 minutes, someone gonna come and change that plastic wrap. So again, it's not 100% protected, but they're decreasing the risk of contamination. Let's talk now about the environmental decontamination. I'm sure like most of you interested in this slide. So workers who conduct the cleaning tasks must be protected from exposure to body fluids, to blood, and other potentially infectious materials, according to Occupational Safety and Health Administration, OSHA.
So the point here is we want to remember to protect those who are doing the cleaning. Never mind the blood issue right now, but the point is that if we're expecting them to potentially be in contact with cleaning this virus over and over and over throughout the day, then there's some heightened risk for them. So we need to be thinking about them and their knowledge of how to protect themselves, such as with gloves and other, what's the safest ways, and they need to wash their hands after doing this each time and so on.
Exactly. So we need to, first, of course, we worry about their safety. And second, we worry about them. If they get infected, they're going to spread it to the whole building or the whole facility, because they're going to be cleaning, supposedly they're cleanings, and instead they're going to be spreading the disease. So we need to make sure these people know how to handle the issue in a correct way. Don't use compressed air or water sprays to clean potentially contaminated surface. Why? Because you might disturb the virus, you might increase it, into
the air.
In the air, again, thank you. So employers should also work with their local and state health departments to ensure appropriate local protocols and guidelines, such as keep updated, getting like additional guidance for cleaning and disinfection, and keep in mind like the CDC always updates their guidelines. The more we know, the better. We want you to know, and all the people to take like more precautions.
So check the guidelines and the date on the guidelines on a regular basis.
So the CDC preventive measures to preserve healthy environment and help slow spread of the virus. Daily sanitation of all conference rooms, classrooms, computer labs, and lecture halls. Installation of more hand sanitizers in the corridors, in the lecture rooms, in the needed areas next to the elevators where people have access to. Frequent sanitation and wiping down of surfaces based on different touch points. So what are we talking about here? Certain areas people gonna be touching all the time. And back to the example we saw before, like the elevator buttons, for example. Washrooms, conference rooms, certain door handles, knobs, and toilet seats, like things that people are gonna be touching all the time, over and over and over.
So those areas that need more frequent sanitation. There's no magic answer for how often. As often as is feasible is really the magic answer right now.
Okay, so how to disinfect areas after suspected cases? And the term disinfect, we all know about cleaning. We need to clean it from dirt, but disinfection means we're using chemicals to clean to lower the risk of the COVID-19. So it's recommended to close off areas used by the ill person. So if you have like a tenant, for example, with a confirmed case, it's better to lock, after we deal with the patient himself, with the confirmed case, we need to close off that area if possible. Wait as long as practical before beginning cleaning and disinfection to minimize potential for exposure to respiratory droplets. Keep in mind, we said that this virus has survival time, so the more this space is locked, the less the chance someone's gonna be contaminated. Open outside doors and windows to increase the air circulation in the area. If possible, and that's again like the CDC, if possible, wait up to 24 hours before beginning cleaning and disinfection of the area. In this slides and the next two slides, we're going to be talking about homeless shelters. So we need to know our data from January 2018. There are almost 500,000 people were counted as homeless in the United States. Of those, like 35% of them were unsheltered according to the state of homelessness in America. A lot of these people experiencing homelessness have multiple pre-existing health conditions, which make them even more vulnerable. Remember when we talked about like the 50% increased chance for coexisting diseases. They also lack the ability to self-quarantine, which means they could more rapidly spread the virus. And now we're not talking, of course, like we care about their safety first. This population is vulnerable population, but we're also talking about the general population. When these people gonna touch something, you're gonna touch that surface within certain time, you're gonna get infected. So that's why it's very important to think about this slide.
It's both a personal protective health issue as well as a public health protective issue to make this population a priority right now. Okay.
So based on that report, which cities in US have the most homeless population? New York, Los Angeles, Seattle, San Diego, San Jose. So we're talking about New York, state of New York, state of California, and Washington. If we go back to our map, if it's possible, we will see that these are the most affected states. We're not saying that these states are most affected because they have homeless population. No, but we're trying to make a link that there is this population, besides being vulnerable, they're located in the states that's most affected. We can go, thank you. So selected guidance for homeless shelters provide, what can we do? What we should do, actually. Provide supplies for staff, volunteers, and those you serve, such as like soap, alcohol-based hand sanitizers that contain at least 60% alcohol. If you remember, we talked about alcohol as disinfection. Tissues, trash baskets, and disposable face masks.
Right. There's never been a better time to give a charitable gift to a homeless shelter.
Yes. Identify space at minimum, a room with a bathroom that can be used to accommodate clients with mild respiratory symptoms and separate them from others. If you remember, like when we talked about the distance, the 6 feet, if any of you been in a homeless shelter, when these people go, if they are lucky to get in the shelter, they don't have the luxury of 6 feet distance between each other. So plan for higher shelter usage during this outbreak as well. Immediately report to your local health department. Cases or clusters you learn about in any living facility, including long-term care unit facility, jail, prison, group homes, or homeless shelters.
Right. They could represent localized outbreaks that need special intensive attention, and the local health department will help coordinate that kind of activity. And then finally, I wanted to make a point about fear, which is, if you watch TV, you know it doesn't take much to jack up one's anxiety level as one is hearing what's going on around us. I want to make the point that we know a lot about coronaviruses, but we have a lot to learn, and that we should all try to be patient with those who are trying to provide guidance. It's basically, this is something that is historically new, and so we need to keep that in mind and be patient with those, because they may not get everything just right. Also, you should beware of letting fear and discomfort and exhaustion with the situation allow you to justify dismissing good advice or exercising reasoned judgment. Be cautious about criticism that refers to educated people as so-called experts. Experts are not going to get everything right, but their advice should not be just dismissed out of frustration. And beware emerging crowd movers who feed on distrust and thrive on situations like we are currently in. Okay, we know this scenario of the elephant and the mouse, and it's one thing to dismiss an elephant being afraid of a mouse. That's not what we're in right now. Okay, this is something different. It's another thing to dismiss an elephant being afraid of a mouse with a virus that infects elephants. Okay, so some of our behavior change is triggered by fear. The behavior change that's helpful that's triggered by fear, hand hygiene, respiratory hygiene, right? Sheltering in place, so to speak. These are things that make sense because we're trying to so-called flatten the curve. We're trying to minimize the impact on the hospitals so that they have enough resources to take care of the surge in cases that we're seeing. Surge in cases occurring because we don't have a vaccine, because we don't have effective treatment available. Okay, however, I do want to end with some hopeful preliminary news that I saw. I don't know much about it yet, but I wanted to share with you that there is a Japanese drug. It may be effective at treating COVID-19. This is the name of the drug, favipiravir, and preliminary data suggests it's most useful to treat early disease. They showed that X-rays improved in about 91% of patients who were treated with this, as opposed to 62% of people who didn't receive treatment. So there was clearly some benefit that was being seen treating people early in their illness. It might not be effective though for people who've already advanced into critical illness that are in the intensive care unit. It may or may not help rescue them, maybe too late, but if they had received it earlier, perhaps it would. So this is something we might hear about more in the coming days and weeks, and it may get rolled out, and so that would be a wonderful thing if we have a drug that people can take if they're diagnosed and have mild illness that might prevent them from ending up in the hospital or needing critical care. So that's something still on the horizon to learn more about. All right, so we're also going to make our resources for our slides available through National Housing Conference, and we're prepared to take some questions, try to answer any questions that you might have.
Great. Thank you so much, Dr. Dworkin and Dr. Almukhtar, for that presentation. We have received everyone's questions coming in as the presentation occurred, and I'm going to try to group them into different groups to answer as many questions as possible. So one area that we're getting a lot of questions about, which was addressed in the presentation, but maybe if there's anything to add, is how the virus spreads. So some things people were wondering about is whether the virus is airborne, how long it can survive in the air, whether rain washes it away, and whether it spreads through mosquitoes. So if there are anything in those areas that either of you wanted to share information about.
Sure, I can address that. So in terms of how it spreads, you understand it spreads from respiratory droplets. When we talk, whether we see them or not, tiny respiratory droplets fly out of our mouth. If you've ever been on a bus or somewhere where there's been bright sunlight, you can actually see this happening. It nicely highlights what's happening all the rest of the time when there isn't bright sunlight. So when we're close to each other, whether it's at a bar and there's loud volume of music and people are shouting to try to hear each other, or at a sporting event, or singing in a choir, or just talking to each other within 3 feet, there is some of this that goes on. That's normal, but obviously right now what we're trying to do is we're trying to make it impossible for the virus to get from me to you and from you to me by just spreading out a little bit. And that can be highly effective, because if the virus can only land on the floor, then we are not likely to get sick. Now that speaks to the issue of what about surfaces. We talked about surfaces extensively, so I won't belabor that issue. But in terms of airborne, as I said earlier, it's a controversial area. There may be some situations where there is some sort of airborne spread. It may linger for a little while in the air, particularly if somebody sneezes, okay, who is infectious with it. But generally speaking, that's not a major issue that we are aware of. I suppose if it was, we would probably be seeing the outbreak even more explosive than we're currently seeing it. And then, it may play some role, and certainly in the hospital, it's a big deal because they do procedures sometimes where these things can happen. How long does it survive in the air? There's no accurate information on that. Most likely briefly before it settles. But we do know from some other viruses that and bacteria that they are able to stay in the air for prolonged periods of time, like more than just a few minutes, like with tuberculosis. And then as far as rain washing it away, I'm sure if it was outside and there's rain, that certainly is going to help. It's probably diluted out too, but it shouldn't make any major effect on this outbreak because most of what's happening is person to person in close proximity. And as far as mosquitoes go, it's unlikely that mosquitoes play a role in this. It's reasonable to look into this further, but at this point, this is all happening mostly in areas that do not have significant amounts of mosquitoes. But again, this is expanding globally, and we're going to learn more about that. But person to person, that's the main thing.
Great. That's very helpful. I think we have a lot of housing professionals on the line, and specifically property managers for multifamily buildings. So we're getting a couple of questions about the owner-agent responsibility for if a resident in a building discloses that they have COVID-19, or how to handle residents who refuse to self-quarantine or continue to use common areas under quarantine. So best, I guess, maybe how to address trying as best you can to quarantine residents who may or may not have the disease.
Okay, well, I think there's an obligation if you have someone in the building that has the virus to alert the people in the building of the situation without naming a person. Now, they may figure it out, that's a whole nother issue. But I think that people need to be aware that their risk is higher than it even was before, because it may trigger proper behaviors. Now, there's a negative side to that too, because it could also trigger panic or anger or any number of things. So it needs to be dealt with on an individual basis, and there's no absolutely right decision there. But that one does need to consider letting people know that in general, somebody in a building does have it, because other people might change their behaviors from ones that were lax to ones that are much stricter, and that's necessary to protect their own health and to control that potential outbreak in the building. On the other hand, the issue of somebody refusing to self-quarantine, as the term says, it's a self-quarantine. People are given the right to do as they please. They ought to do self-quarantine. And so I don't think you really have anything that you can do there in response to that.
If I can add, so we're recommending, like besides following the CDC guidelines, that you talk to your local health officials, especially in events of property quarantine, because probably they would be able to handle it better. When we look at the CDC guidelines, it's general guidelines. That's why, like, besides looking at the CDC guidelines, you need to also contact your local health officials. Probably they can help you with specific cases in a specific areas.
And they may also come up with a regulation for your building that will help you take the burden off of you on what to do. They'll tell you.
Great. A couple of other questions on the subject of hand sanitizer, which was addressed. Just running through these, what percentage of alcohol in hand sanitizer is recommended? Is it advisable to use non-alcohol based hand sanitizer? And then if you could walk through the difference between washing your hands with soap and water versus just using hand sanitizer.
Okay. I don't have memorized the concentration, but you do want alcohol-based hand sanitizer as opposed to the non-alcohol-based hand sanitizer. In terms of the difference between using that versus hand washing is superior. There you're going to agitate the virus and then rinse it off. And then the drying with the paper towel also is going to take off a little bit more and reduce the amount of virus on your hands to either so little you're not likely to get infected or basically none. Alcohol-based hand sanitizer should be considered the next best thing. When you don't have hand washing facilities available, then that's the best thing to do. If your hands are visibly soiled for any reason, then you always would prefer to do soap and water washing rather than alcohol-based hand sanitizer.
Great.
So far, the CDC recommend 60% or higher for the alcohol concentration percentage.
Got you. A couple of questions about whether if someone has the virus, are they then immune from contracting it again?
We don't know that because there hasn't been time to determine much in terms of reinfection. Sinan is signaling me that there appears to have been one case that looks like it might have been reinfected. You know, what was that person's immune system like? We don't know. Currently, it's not known to be a major issue. We will learn more as studies come out over the next year.
Great. A couple more questions about how the virus spreads. Is, you know, petting animals, cats or pets, a means of spread? Also, buying groceries at the supermarket or ordering takeout, are those risky?
Okay, so petting an animal is a potential risk if this animal has been pet by somebody else as well who might have it. So, you know, just like we would always recommend anyways, but a lot of people don't do, wash your hands after contact with an animal, even your own pet. In terms of groceries, there's definitely a theoretical risk that somebody is going to be at risk when they're touching groceries, because people often touch the produce and put it back and do other things, and then you've got the grocery cart and so on. So when you enter a grocery store, you should consider it a public space, and you should basically plan to either, you know, limit your touching and also to wash your hands or use a hand sanitizer immediately after, and to avoid touching your eyes, nose, and mouth. But we need groceries, so you know, we definitely don't advise not to go, but you should understand you've entered a public space and then you need to take appropriate measures right away afterwards. And as far as takeout food goes, you know, there's a theoretical risk that any food that was touched by somebody else, you know, could then possibly transfer the virus. But we also know from like when we travel to foreign countries, people advise, you know, eat foods that are steaming hot. So if you're ordering hot foods and when you're eating them, they're steaming hot, or you just put them in the microwave and return them to steaming hot, that food should be very safe. On the other hand, if you're ordering salads, things that are ready to eat that may have been handled, then there could be some risk for those sort of scenarios. We don't know that that's how anything has been transferred, but you know, steaming hot food is you can be sure that's the safest, because we know that heat is unfriendly to germs.
And I would worry about the packages that the food comes in, besides like the food itself. So just make sure, like when you handle the package, like you're handling any surface, when you open the package, you wash your hands. Again, wash your hands, please.
Great. So we know that we have, you know, it is past 12:30, so understand if people are dropping off, but if it's okay, there are a couple of questions, a couple of additional questions that people have that we can just go through quickly.
Okay, I'll take them.
So a couple other questions related to sort of property management. One person who's managing a senior living facility is wondering whether it's advisable to shut it down to visitors. We're also having people wondering about best practices for cleaning a room that was lived in by someone who had the disease, and whether it's advisable to leave it empty for a certain period of time. and then also best practices for cleaning laundry facilities, whether you need to clean the inside of the system or the machines in addition to just the buttons and the things that people touch.
Okay. In terms of the senior living facility, I think that it is prudent to limit or discontinue visitors in the short term, because basically, as we know, these are the most vulnerable, the most likely to get very sick and die. And so, and also if they get sick, then spread to others in their facility. You know, we're seeing that play out, and it's not unusual that we see, as people know, flu outbreaks in these kinds of facilities. You can't eliminate their risk completely, because obviously the people who work in these facilities will come and go within the community and come into the facilities and interact with these people, often in close contact. So you can't eliminate their risk entirely, but it is prudent to limit or shut down visitors in the short term in an effort to protect them. In terms of cleaning a room of a case, besides what we provided, I would say you'd want to contact your local health department and seek the guidance from them, or the state health department, where the guidelines will be found, and or look for the CDC guidelines, because there'll be more specific information there. In terms of cleaning the inside of a machine, like a laundry machine, that does not seem to be necessary. The machine should be cleaning each time sufficiently on its own, internally.
Great. A question for homelessness service providers. When isolating those with symptoms in homeless shelters, are you ideally isolating those with symptoms together, like all of those exhibiting symptoms in one area and those not in another area, or do you want to separate individuals who are exhibiting symptoms from each other?
You want to isolate them from each other, but I understand that in a homeless shelter, very often they won't have space to do that. I think that when you have a scenario like that, your first call is to the local health department and to appeal for them to help them get this individual out of there. And appeal for them based on what's at stake in terms of an outbreak, to seek out where in the community someone might be able to volunteer a space. Like, well, I don't know, I leave it up to the local health departments. They're more likely to have the measures to figure out where else some room could be opened up. They should be having some sort of planning and you know, thinking about these kinds of issues. So I would turn to them to try to get the individual completely out of the facility.
Got you. And then just in terms of the timeline of the crisis, we have a couple of questions about that. One being, there are reports that it could last upwards of 18 months. And we have another person wondering about whether this is only potentially phase 1 and whether it could get worse next flu season.
Okay, so we're in the realm of projections here. And obviously we don't have a crystal ball, but I think it's fair to say that since we don't have a vaccine currently, and since we don't have effective treatment widely available, and since we don't have the ability to make everybody do exactly what they need to do in order to stop the spread of the virus, that this is likely to be prolonged, that we're likely to see our current aggressive social isolation measures improve things, but not stop things. And so as far as like another phase or wave, that's true. When we have a pandemic flu, there's usually another wave that occurs within the same year. It would not be surprising to me if we see so-called flattening of the curve, and then we see some sort of rise in the curve, and we're called again to, you know, be aggressive with our behaviors. That wouldn't surprise me, but we're going to wait and see. We may get lucky. No way to know.
If I may add, one of the good news I hear today, there are no new cases in Hunan for today.
Right, which is interesting and hopefully true.
Great. Well, I understand that we've gone over by a little bit. We have a couple more questions that are more on the housing side. So I'm going to ask the NHC President and CEO, David Dworkin, whether he can answer those. But we really appreciate Dr. Dworkin and Dr. Almukhtar, both of you taking the time today to join us and impart this really, really invaluable information. So David, we have a couple of people wondering about whether HUD will still expect residents to be responsible for their rent portions or portions of their rent during this period, or whether HUD will release them from their commitment and cover their rent themselves.
So thank you, and thank you so much to Dr. Almukhtar and Dr. Dworkin. This was incredibly useful and enlightening for me, and I know for many of our members as well. We know how incredibly busy you are. I know you've been getting texts while the presentation was going on, and I appreciate the time and dedication. We are going to be seeking expertise like this more broadly in the future. We want to be able to give our members this kind of information on an ongoing basis. On the question that's been asked about the voucher program and about the portion of the rent that's paid for by the resident, we are in regular contact with HUD at the highest levels. I've already texted them to ask the question, and we will post an answer on our website as soon as we have a definitive response from the FHA Commissioner's Office and the Deputy Secretary.
Great. I'm going to actually transition back so that I will be the presenter. We have another question related to multifamily workers in New York. Person is wondering, are multifamily staff in New York considered essential according to the standards set by the New York government? Wasn't sure whether the multifamily staff are considered essential in senior and disabled apartments. So I don't know if you can speak to that, David, but it might be something that we, get back to the person and publish on our website.
Yeah, we will do that. I did see Governor Cuomo's press conference earlier today when he talked about essential workers. He didn't mention that specifically, but I think that's a question for the New York Department of Public Health, and we will follow that up.
Great. A couple more housing related questions. Do you know if the IRS/HUD will be relaxing rules regarding notary of self statements? Also, have you heard if they will be extending recertification deadlines?
I am aware that that's an issue. We've heard it from many of our members, and we are following up with the IRS to try to get an answer as soon as possible.
Great. And then lastly, a question about relief/forbearance on multifamily debt. And whether there's been any discussion with lenders on that issue.
So we are in regular contact with the MBA on that, as well as Fannie Mae and Freddie Mac and FHA multifamily. We will get a specific answer on that. They have announced forbearance policies, but we want to make sure that it applies to multifamily loans as well as single family.
Great. Okay, so we understand that we've run 15 minutes over. So I think it makes sense to wrap this up here. Again, we have received everyone's questions, and we want people to know that we will be looking at them, consulting with experts, and trying as best we can to publish answers on our website. So please, if you have any additional questions, or if you don't think that your question was answered in today's webinar, feel free to email me at qmulholland@nhc.org. We will be continuing to take and answer questions and to try to serve as a public resource on this very important issue. Again, the recording of this webinar will be posted online. David, do you have any final words?
No, just thank you all for attending. We appreciate the attendance, and I also appreciate those of you who have reduced the number of staff that dialed into the call. We wanted to make sure that we were able to use the bandwidth appropriately and share the information immediately afterwards. We had a lot of people. I know that your staffs are working from home, and we will make sure that you get all the information so that you can distribute it as quickly as possible. So thank you all for your patience on that, and we will be in touch on a regular basis.
Great. So again, email me if you have any further questions. And thank you everyone for joining. Stay safe out there and have a great rest of your day.